I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about something I get a lot of questions about, which is luteal phase defects and progesterone testing. And so, thinking back to the menstrual cycle, we know that a typical menstrual cycle is around 28 days, although there can be a lot of fluctuation. Even down to 25, 26 days can be normal. And as long as 35 days is technically normal. As the cycles get shorter and longer, I start to wonder if something's going on. But the luteal phase is basically the time from the time of ovulation, which we say, when the LH surge happens, ovulation happens within the 24 hours following until the onset of menses, right? In a non-pregnancy cycle, or until 14 days later when we detect a positive pregnancy test in a pregnancy cycle. And so that luteal phase, and I guess you could argue even that the luteal phase extends once somebody is pregnant because the HCG rescues the corpus luteum, but that's getting super nerdy. I think, thinking about, what is the function of the corpus luteum? And when we have the egg that is released from the follicle, right, that it signals ovulation, that follicle then reforms, and there's what's called a luteinization of those cells. And the cells then make progesterone in addition to estrogen, and those hormones sustain, hopefully, in early pregnancy if there's implantation about a week later. And so when we think about it, the corpus luteum has to be robust enough to make adequate hormones, for the implantation, right, to maintain that implantation. But the other function of the corpus luteum is that is creating negative feedback. Those ovarian hormones, the estrogen, progesterone, are creating negative feedback, which suppresses the pituitary hormones, right? So notably the follicle stimulating hormone, so that only if a person's not pregnant, right, and those estrogen, progesterone hormones start to fall, once somebody does have a period, then the FSH starts to rise naturally. Now, interestingly, if somebody does not have sufficient luteal phase hormones, notably progesterone, and those hormones start to fall too early, that's when you can see a premature rise of the FSH. People can start to bleed sooner, and that's thought to be an inadequate luteal phase. And so thinking about that, typically the luteal phase in a menstrual cycle is what's the most conserved portion, right? If you have a 35-day cycle, typically your luteal phase is 14 days and your follicular phase is 21 days. And if you have, say, a 25-day cycle, then your follicular phase will be 11 days and your luteal phase will be 14. But thanks, we have ovulation predictor kits. And so if your luteal phase from the time that you have the LH surge to the time that your period comes is less than 12 days, that can suggest that there might be an underlying issue. So, I think that if you think about old school fertility, diagnosis, they actually used to do endometrial biopsies to try and understand where the endometrium was, in relation to the ovulation, and if people had what was thought to be like a defective luteal phase. But interestingly, now we base it more based on timing, right? If somebody says, okay, well, I, ovulate on day 14, it seems, and then I get my period 10 days later, that's somebody that I think might have a luteal phase defect. As if your progesterone's not high enough and it's not staying high enough for long enough, that may not be sufficient to maintain an early pregnancy. And so that's really why we care. Another clinical sign that sometimes goes along with luteal phase defect is actually premenstrual spotting, right? And based on what we just shared, it does make sense why that might happen, right? Because the hormones are breaking down. And so we know that when the hormones fall, that then causes the endometrial lining to break down as well from the withdrawal of the hormones. But that premenstrual spotting can often be a tip off too. But just so we don't really call the first day of the menstrual cycle cycle day 1 until people have flow where they need to use like a pad or a tampon. So it's just kind of for counting purposes how we look at things. Okay, so what can be done for a luteal phase defect if somebody does have a true luteal phase defect? Well, as an REI, I like to put my detective hat on and I like to understand, well, why is somebody having a luteal phase defect, right? I'd say one of the most common causes of luteal phase defect is actually PCOS because the menstrual cycle is a choreography, right? It should be a cylinder, not a straight line when we look at the diagrams in the textbook. And so it's a cycle, right? One part of the cycle sets the stage for the next part of the cycle, and then on and on and on. So one of the problems with PCOS is that people can have a hard time growing a follicle, right? It can take a long time to grow that follicle. Maybe the ovulation dynamics are kind of crummy, like it's an LH surge, but it's not the best surge. There's all sorts of reasons why for people with polycystic ovarian syndrome or ovulatory dysfunction that they might have, kind of a crummy ovulation, so to speak. And so if people have a crummy follicular phase leading to a crummy ovulation, one could imagine that that corpus luteum may not be the most robust because the previous phase of the cycle did not set the stage for a successful cycle in that second half. And so if we think about it, yes, we can give progesterone to help augment that luteal phase, right? That's one of the things that people do. But from my perspective, that's kind of like putting a band-aid on the problem instead of correcting the problem at the source. And so I prefer to do letrozole for people with PCOS because that often will give a more robust ovulation, right? A healthier follicular phase, and we can even augment with an HCG trigger. And then typically we don't even need to give supplemental progesterone because again, we've augmented and fixed the first half of the cycle, setting the stage for a better luteal phase. So that's, how I practice. I know a lot of other REIs who do that as well, but I think we have to kind of think physiologically, what's really the goal? Is the goal to supplement a crappy process, or should we try to augment the whole process altogether? And I think most people would say the latter for sure. Another reason people can have a short luteal phase is diminished ovarian reserve. Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan, I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye. And so we know that as people get older, egg quality starts to suffer. The follicle dynamics kind of start to obey different rules in terms of the thresholds. And sometimes people can fire off a follicle even at like 12 or 14 millimeters, right? And so if you're thinking about it, if the thresholds are different and the follicular dynamics are different, sometimes that can lead to a shorter luteal phase or, spotting before the period comes on. And that is also a situation where adding some augmentation to the follicular phase, such as letrozole or clomiphene or even FSH. I love FSH when there's diminished ovarian reserve, right? Sometimes even a hybrid cycle where we can give a little bit of letrozole in the beginning to kick off the cycle and a little bit of FSH to then hopefully aim for multifollicular development. Those are some strategies to, again, improve the follicular phase so that we have a better luteal phase down the line. Okay, now let's talk a minute about recurrent pregnancy loss. So one of the thoughts, for why people can have recurrent pregnancy loss, obviously there's a long list, but that people are not having adequate progesterone to maintain an early pregnancy. And so, that certainly can happen. I have seen many people in my practice where they are having ovulatory dysfunction and then the luteal phase is shorter. Even PCOS, I mean, everybody says, well, why do people with PCOS have higher rates of miscarriage? I personally think that it's related to this luteal phase that may not be as sufficient. And so, yes, in fact, for recurrent pregnancy loss, there are some data that if you give luteal progesterone, that can help ongoing pregnancy rates, and that makes sense. Although when I see people, and maybe I think they may be a little on the PCOS spectrum and they also have recurrent pregnancy loss, I also love to give these people letrozole because that, again, corrects the problem at the source, and then people can have a better luteal phase, and that will often get them to have a sustained pregnancy, especially if they're young and have good egg health, whereas they may have had miscarriages prior. Okay, so again, trying to understand the source of why the menstrual cycles are short, specifically short luteal phase, typically involves some sort of ovulatory dysfunction, and then correcting the problem at the source to try to overcome the short luteal phase. Okay. Now let's talk a little bit about progesterone levels. And so, gosh, I have very strong feelings about checking progesterone levels in natural cycles because if you think about the physiology, the progesterone is secreted in a pulsatile way. And so they've done studies where you can check a progesterone level, anything over 3 suggests that somebody's ovulated, right? 3 nanograms per milliliter. And then sometimes people say, well, should it be above 10? Should it be above 15? Should it be, they even look, you can have a progesterone level of 25 in a natural cycle luteal phase. Like, we don't really know because unless you had an indwelling catheter, it would be very, very hard to see exactly what those levels were doing. And so, what I'd like to know, if I check your progesterone level and it's 6, well, if that's the trough, right? If that's the lowest point, well, then that's fantastic, right? Because this is a pulsatile secretion. But if that's the peak, if your peak progesterone level is 6, then that's not so great in terms of being able to maintain a pregnancy. And so, again, thinking about the source, but a lot of people are like, let's check a progesterone. If it's less than 5, that's not very good. If it's between 5 and 25, that's intermediate. If it's above 25, then that's much more reassuring for a normal pregnancy. But I think what we forget to realize is that, again, this is a dynamic system. And so when we're talking about low progesterone levels in an early pregnancy, even, what we're really talking about is a lot of times egg health, right? And the quality of the pregnancy itself, and not necessarily like the luteal phase in and of itself. And again, it's secreted in a pulsatile way. So it's really hard to determine like what's normal. Really, so I like to take the qualitative aspect out of it and say, okay, progesterone, if I'm going to check your progesterone, it's going to be quantitative. And, if it's above 3, you've ovulated. If it's below 3, you probably haven't ovulated. And just to say it's more like, black and white rather than I'm going to make some judgment about the quality of the luteal phase based on your progesterone level, because truly I just can't do that. It also gets tricky if people do decide to take luteal progesterone because that progesterone does, add to your overall progesterone level in your body. And so it's really hard to say, okay, well, if you're on 200 milligrams of micronized progesterone every night, like what's coming from the ovary, what's coming from the supplemental progesterone. And to even add more to the mix, if people are taking that suppository vaginally, right, the progesterone vaginally, there is local absorption that's not even reflected in the serum values. And so you can see that it gets very, very murky, again, not knowing exactly where the progesterone is coming from. And, knowing that endogenous progesterone secreted in a pulsatile way, I personally find that checking progesterone levels in natural cycles is really not that useful. It's more based on the history and the length of the luteal phase. Again, I like that luteal phase to be 12 days or greater because that tells me that the progesterone exposure is adequate to maintain an early pregnancy, right? If it's less than that, or if it's shorter, then we got to figure out what's going on. And then, progesterone absorption, I think we think about this a lot more typically in IVF cycles where the entire pregnancy is dependent on the external hormones, or even in a fresh transfer, right, where the corpus luteums have been gone through to get those follicles. And so maybe there's some compromised function there. It's interesting, many programs like the progesterone to be above 15 nanograms per ml. But I think that if you look at it, many programs will go down as low as like 8 or 10. And so again, I wish I knew exactly what the right level was in IVF cycles and intramuscular progesterone. People do seem to metabolize that pretty well. And I personally like the level to be above 15, although if somebody's at 14, am I going to adjust their dose? Like probably not. But again, I think thinking about luteal supplementation in a process that's entirely dependent on progesterone from the outside world, that's a very different situation than, a natural cycle where there is some endogenous progesterone going on. They've actually even looked at, in a frozen embryo transfer cycle where there is, the need for intramuscular progesterone because it's a completely medicated cycle, you can actually give intramuscular progesterone every 3 days and vaginal progesterone in the meantime with comparable pregnancy rates, comparable ongoing rates. It's really only when people only gave vaginal progesterone during those cycles that you started to see a decrease in the ongoing pregnancy rate, which corresponds obviously to an increase in miscarriage rate. So, again, luteal phase defect, I think it is a real thing. I think it does contribute to difficulty getting pregnant, difficulty staying pregnant, especially for people with some recurrent pregnancy loss and maybe PCOS. I think it's definitely a real thing. Also, diminished ovarian reserve, we see this as well with the shorter luteal phases and the premenstrual spotting. But I think, again, let's not put a Band-Aid on things. Let's correct problems at the source. Let's understand the why if we don't have a diagnosis, and then also understand that, checking progesterone levels qualitatively in a natural cycle it's really hard to make judgments about that. Sure, if somebody's wondering if the trigger worked or if their LH surge, yielded an actual ovulation event, we can check a progesterone level. But personally, I don't find it that useful in clinical practice. So I hope this was helpful. More to come. You know how much I love you. Bye.